1. A 72-year-old man is referred for a cardiology evaluation after his primary care physician noted the presence of a loud systolic ejection murmur. Transthoracic echocardiogram shows normal left ventricular size with a left ventricular ejection fraction LVEF of 65%. The left ventricular outflow tract LVOT diameter is 2 cm, and the LVOT time velocity integral TVI is 15 cm with a peak velocity of 0.8 meters s. The peak aortic velocity is 4.8 meters s and the aortic valve TVI is 100 centimeters. Your interpretation of the echocardiogram is: A. Severe aortic stenosis is, because the valve area is less than 1 square centimeter. B. Severe is, because the LVOT aortic velocity ratio is less than 0.3. C. Severe is, because the peak aortic velocity is greater than 3.5 meters s. D. The severity of the is cannot be determined from the data presented. Submit. 1. Chapter 16. Answer. A. The Doppler findings are consistent with severe as. Valve area can be calculated with the continuity equation. The basic formula is: in the example, the aortic valve area calculates at 0.47 square centimeters. Answer B refers to the dimensionless index, LVOT aortic TVI or velocity ratio, which is shown to accurately predict presence of severe as when the ratio is less than 0.25, rather than 0.3. This measurement avoids the use of LVOT diameter, which is the largest source of errors in aortic valve area calculations. This is due to the inherent difficulty associated with the measurement in the presence of a heavily calcified valve. Chapter 2. In this asymptomatic patient in question 1, the most appropriate recommendation is: A. Inform the patient that the chance of developing symptoms in the next 5 years is 20%. B. Recommend coronary angiography in anticipation of surgical intervention. C. Recommend transesophageal echocardiography. D. Recommend oxygen consumption treadmill test. E. Recommend repeat echocardiogram in 2 years. Submit. Chapter. That's correct. Answer. D. The evolution of completely asymptomatic AS is not benign. Several studies have shown that once the stenosis is severe, patients will inevitably develop symptoms. Rosenheck et al. Have shown that among 128 patients with asymptomatic severe AS, only 47% were free of death or aortic valve replacement after 2 years. Pilicka et al. Have shown that among asymptomatic AS patients with aortic velocities greater than 4 meters s at baseline, only 33% remain free of symptoms after 5 years. Therefore, Chap. A. Echocardiographic maximum aortic. 3. Which of the following statements referring to the echocardiographic evaluation of AS is correct? A. Echocardiographic maximum aortic gradient is usually higher than the pullback gradient obtained during left-sided heart catheterization. This is due to overestimation of the true gradient by echocardiography. B. Echocardiographic assessment of mean aortic gradient correlates well with the mean gradient obtained in the cardiac catheterization laboratory. C. The usual echocardiographic measurement of the mean aortic gradient cannot overestimate the true gradient. D. The assessment of mean aortic gradient with a non-imaging probe is more accurate because these probes allow for better Doppler software processing. Submit. Chapter. That's correct. Answer. B. The peak-to-peak gradient typically evaluated at pullback in the cardiac catheterization laboratory does not reflect a true event, as the peak aortic pressure occurs after peak left ventricular pressure when as is present. Echocardiographic estimation of the peak aortic gradient is more accurate as it reflects instantaneous pressure differences between aorta and left ventricle. Answer A is false. Statement B is correct in the vast majority of situations and has established echocardiography as the main diagnostic tool in valvular disease. A number of assumptions are made in echocardiographic assessment of valvular stenosis. If these are not accurate, Doppler-based estimations can be erroneously high. Answer C is false. The simplified Bernoulli equation estimates the pressure gradient according to the formula P equals 4v2. This, in turn, is a simplification of the convective acceleration term in the original Bernoulli equation. The number 4 in the simplified formula is the approximation of the converted for expressing pressure in mmHg units. It assumes a blood mass density of 1060 kgm3. However, blood mass density is lower when significant anemia is present, which would lead to overestimation of the pressure gradient if the same formula is applied. In addition, conditions with increased cardiac output, anemia, fever, subvalvular AS, significant valvular regurgitation will increase the inflow velocity V1, which is usually considered negligible. This also leads to overestimation of pressure gradients. Answer C is false. Chapter 6. 4. A patient is evaluated for AS. Doppler measurements from all available windows show a highest peak aortic velocity of 5 meters s, and an LVOT velocity of 2 meters s. Which of the following calculations are correct? A. Peak aortic valve gradient is 116 mm Hg. B. Peak aortic valve gradient is 100 mm Hg. C. Peak aortic valve gradient is 84 mm Hg. D. Peak aortic valve gradient is 36 mm Hg. Submit. 1. 2. Chapter 6. Multiplication sign. Hyphen. That's correct. Answer. C. Since the aortic valve inflow velocity, LVOT velocity, is 2 meters s, the term V12 cannot be ignored in the Bernoulli equation. The full formula has to be used. Therefore, the calculation using the Bernoulli equation would be 116 mm Hg or 84. Chapter 5. A 30-year-old woman is referred for management of a newly diagnosed subaortic stenosis. She is asymptomatic, but during a routine physical examination a loud systolic murmur was heard. An echocardiogram demonstrated a subaortic membrane with a gradient of 44 mm Hg and concomitant presence of moderate aortic valve regurgitation. The left ventricle is borderline enlarged, with an LVEF of 57%. At T, the aortic valve does not appear to be calcified. Which of the following statements are correct? A. This type of lesion responds well to balloon dilatation. B. The patient should undergo resection of the subaortic membrane and aortic valve replacement. C. Careful inspection of the pulmonary valve and pulmonary artery should be carried out during T. D. Doppler interrogation of the abdominal aorta provides no information in this case. Chapter A. This type of lesion responds well to balloon dilatation. B. The patient should undergo resection of the subaortic membrane and aortic valve replacement. C. Careful inspection of the pulmonary valve and pulmonary artery should be carried out during T. D. Doppler interrogation of the abdominal aorta provides no information in this case. Multiplication sign. Hyphen. That's correct. Answer. C. Subaortic stenosis does not respond well to balloon dilatation. The only treatment is surgical resection. Answer A is false. Presence of moderate aortic regurgitation is an indication for surgery, as further valve deterioration is expected due to a jet lesion from the subaortic acceleration. However, a non-calcified aortic valve is generally repaired rather than replaced in a young patient. Answer B is false. Associated lesions must be evaluated. The most common are patent ductus arteriosus, Pulmonary valve stenosis. Both can be diagnosed during T examination of the pulmonary artery and bifurcation. Answer C is correct. Coarctation of the aorta, which can be diagnosed by pulsed Doppler of the abdominal aorta. Answer D is false. And ventricular septal defect. 1. Chapter 16. Aortic valve disease. 24 questions. 6. Which of the following statements regarding aortic regurgitation AR is correct? A is a radius of 0.8 cm with an aliasing velocity of 40 cm s and a peak aortic regurgitant velocity of 4 m s is consistent with severe AR. B. A pressure half-time greater than 250 milliseconds is consistent with severe AR. C. Vena contracta is best evaluated from the apical long axis view. D. The use of the suprasternal notch window is not useful in the assessment of AR. Chapter 16. Based on Answer A. This question refers to the proximal isovelocity surface concept in calculating the effective regurgitant orifice area, AROA. According to the continuity equation, the flow converging to the valve must be equal to the flow through the valve, as blood flow accelerates toward a narrowing orifice, in this case the regurgitant orifice. The spatial distribution of points in which the fluid has the same velocity, isovelocity surface, is approximated by a hemisphere. Based on this concept, one can transcribe the continuity equation as consistent with severe AR. Answer A is correct. A pressure half-time of less than 250 milliseconds is consistent with severe AR. The vena contracta is best measured on the parasternal long axis. Best axial resolution. In the apical long axis view, the vena contracta will be typically parallel to the ultrasonic beam, reducing the spatial resolution. Answer C is false. The suprasternal notch window allows Doppler evaluation of flow reversals in the descending thoracic aorta. Holodiastolic flow reversals are suggestive of severe AR. Answer D is false. Chapter 16. Aortic valve disease. 24 questions. 7. Which is the most compatible with the aortic valve presented in Figure 16-1 AD? A 75-year-old man with tricuspid moderate as. B. A 35-year-old man with a bicuspid as with fusion of the left and right coronary cusps. C. A 35-year-old man with a bicuspid as with fusion of the non-coronary and right coronary cusps. D. A 35-year-old man with a bicuspid as with fusion of the non-coronary and left coronary cusps. Figure 16. 1. Submit. 2. Chapter 16. Aortic valve disease. 24 questions. 7. Which is the most compatible with the aortic valve presented in Figure 16-1 AD? A 75-year-old man with tricuspid moderate as. B. A 35-year-old man with a bicuspid as with fusion of the left and right coronary cusps. C. A 35-year-old man with a bicuspid as with fusion of the non-coronary and right coronary cusps. D. A 35-year-old man with a bicuspid as with fusion of the non-coronary and left coronary cusps. Figure 16-1. Submit. 2, 3, 4, 5. Chapter 16. Aortic valve disease. 24 questions. 8. Which of the following is the most accurate interpretation of the images of the aortic valve left ventricular outflow tract aortic root presented in Figure 16-2 AD? A. Severe as. B. Systolic motion of the anterior mitral valve leaflet. C. Severe subaortic stenosis. D. Severe supraaortic stenosis. E. The Doppler signal is that of mitral regurgitant flow and not that of transaortic flow. Figure 16.2. Multiplication sign. Hyphen. That's correct. Answer. C. Parasternal long and short axis views show a normal aortic valve. Thus, answer A is not correct. In the parasternal long axis views, the distance between the anterior leaflet of the mitral valve and interventricular septum is sufficient and cannot explain the high gradient velocity measured by continuous Doppler. Thus, answer B is wrong. The continuous wave Doppler jet shown in figure 16.2 has the contour shape and duration of transaortic flow, and answer E is thus not correct. Color Doppler shows aliasing of the velocity below the aortic valve, indicating that flow acceleration is at the subvalvular level. The correct answer is thus CT confirms the presence of a membrane in the 55 outflow tract causing the severe subvalvular stenosis. Figure 16.11. Figure 16.11. 3-chamber view centered on the 55 outflow tract showing a subvalvular membrane. Chapter 16. Aortic valve disease. 24 questions. 9. What are the severity and main mechanism of the AR presented in figure 16-3a? B. A. Moderate AR with aortic annulus dilatation and normal cusp motion. B. Severe AR with aortic annulus dilatation and normal cusp motion. C. Moderate AR with aortic cusp prolapse. D. Severe AR with aortic cusp prolapse. E. Moderate AR with aortic cusp restriction. F. Severe AR with aortic cusp restriction. Figure 16.3. Multiplication sign. Hyphen. That's correct. Answer. D. The regurgitant jet. Color Doppler looks at least moderate and the left ventricle in the parasternal long axis view is severely dilated 7 cm. Hence, AR is likely severe. Answers A, C, and E are wrong. As shown in the parasternal long axis view, the aortic annulus is not dilated and the leaflets are not restricted. Thus, answers B and F are wrong. However, the right coronary cusp is prolapsing in the 55 in diastole. Thus, the correct answer is D. The prolapsing leaflet is better documented by T. Fig. Chapter 16. Aortic valve disease. 24 questions. 10. What is the most probable etiology of the mass visualized in this 50-year-old patient? Figure 16-4ac. A. Myxoma. B. Papillary fibrolistoma. C. Infectious vegetation. D. Rhabdomyoma. E. Paraganglioma. F. Thrombus. Figure 16.4. Multiplication sign. Hyphen. That's correct. Answer. C. Myxomas are generally located in the left atrium. Thus, answer A is wrong. Thrombi on native valves are extremely rare. Thus, answer E is unlikely. Paraganglioma could be located in the aortic root but generally occurs in young adults and is relatively immobile. Thus, answer E is wrong. Rhabdomyoma could be located in the 55 outflow tract and or at the level of the aortic valve. However, it occurs most often in children younger than 4 years. Thus, answer D is not correct. Papillary fibrolistoma are often located on the cardiac valves but are smaller, 1 cm. Thus the most probable etiology of the present mass is endocarditis. The correct answer is thus C. Figure 16.12. 3-chamber view in diastole without N with color showing on the left side the prolapse of the aortic cusp and on the right side the eccentric aortic regurgitant jet. Chapter 16. Aortic valve disease. 24 questions. Case 1. An 81-year-old man presents for evaluation of AS. He has a history of hypertension, pacemaker implantation, and atrial fibrillation. He presents with dyspnea that worsened progressively during the last 3 months and a few episodes of angina during exercise. Figure 16.5 shows the evaluation of the aortic valve hemodynamics. This patient has a normal 55 outflow. Stroke volume index 50.7 ml/m2. Figure 16-5a. In the apical 5-chamber view, Figure 16-5b, the peak aortic jet velocity is 3.7 meters s. The mean transvalvular gradient is 36 mm Hg, and the aortic valve area AVA is 1.01 square centimeters. Figure 16-5c also shows the measurements of transvalvular gradient from the right parasternal window. By two-dimensional echocardiography, the 55 systolic function is preserved. Videos 16.1 and 16.2, with an 55 ejection fraction estimated by the biplane Simpson method of 60%. The 55 end diastolic diameter is 51 mm, 55 outflow tract diameter 26 mm, and ascending aorta diameter 39 mm. Figure 16.5. Browser issues. Video 16.1. Browser issues. Video 16.2. 11. What would be the appropriate management of this patient? A. The AS is moderate and a follow-up echocardiogram can be obtained in 1-2 years. B. The AS is severe but a watchful waiting strategy is appropriate and a follow-up echocardiogram can be obtained in 6 months to 1 year. C. The AS is severe, the patient is symptomatic, and surgical aortic valve replacement AVR is recommended. D. The AS is severe, the patient is symptomatic, but given the patient's age and comorbidities, transcatheter AVR is recommended. Multiplication sign. Hyphen. That's correct. Answer. C. This patient has severe stenosis as defined in ASE and ACC AHA guidelines. Table 16.1. In this patient, the highest velocity and gradient were not recorded from the apical 5 or 3-chamber views but from the right parasternal view. Indeed, in about 30%-35% of patients, the highest velocity is obtained in views other than the apical ones. This raises the importance of performing multiple windows, apical 5-chamber, apical 3-chamber, right parasternal, suprasternal, for accurate measurement of transvalvular velocity and gradient in patients with AS. Table 16.1. Recommendations for the grading of AS severity. Mild, moderate, severe. Echocardiography. Peak aortic jet velocity, MS. 2.6 to 2.9. 3.0 to 3.9. 4. Mean gradient, mmHg. 20. 20-39. 40. Aortic valve area, cm2. 1.5. 1.1 to 1.5. 1.0. Indexed AVA cm2/m2. 0.90. 0.61 to 0.90. 0.6. Velocity ratio. 0.50. 0.26 to 0.50. 0.25. Computed tomography. Aortic valve calcium load AU. Men. M-. M-. 2000. Women. M-. M-. 1200. Aortic valve calcium density. OCM2. Men. M-. M-. 500. Women. M-. M-. 300. AVA, aortic valve area. A velocity ratio or Doppler velocity index, ratio of the 55 outflow tract TVI to the aortic jet TVI, where TVI is the time velocity integral. B. The density is the calcium load divided by the cross-sectional area of the aortic annulus. Furthermore, the patient reports recent onset of symptoms dyspnea and angina, likely related to AS. This patient thus has a Class I indication for AVR according to the guidelines. Table 16.2. However, despite his older age, he has an estimated low surgical risk. The Society of Thoracic Surgeon STS score is less than 4%. He is not frail and has no compromised major organs. Hence, this patient should undergo surgical AVR and there is no indication for transcatheter AVR according to current guidelines. Table 16.2. Recommendation for intervention in AS. Recommendations. COR. Low. AVR is recommended with severe high gradientas who have symptoms by history or on exercise testing. Stage D1. Capital I. Capital B. AVR is recommended for asymptomatic patients with severe AS. Stage C2 and LVEF. 50%. Capital I. Capital B. AVR is indicated for patients with severe AS. Stage C or D, when undergoing other cardiac surgery. Capital I. Capital B. AVR is reasonable for asymptomatic patients with very severe AS. Stage C1, aortic velocity 5.0 meters s, and low surgical risk. IIA. Capital B. AVR is reasonable in asymptomatic patients. Stage C1 with severe AS and decreased exercise tolerance or an exercise fall in BP. IIA. Capital B. AVR is reasonable in symptomatic patients with low flow low gradient severe AS with reduced LVEF. Stage D2 with a low-dose dobutamine stress study that shows an aortic velocity 4.0 meters s or mean pressure gradient 40 millimeters Hg, with a valve area 1.0 square centimeters at any dobutamine dose. IIA. Capital B. AVR is reasonable in symptomatic patients who have low flow low gradient severe AS. Stage D3 who are normotensive and have an LVEF 50% if clinical, hemodynamic, and anatomic data support valve obstruction as the most likely cause of symptoms. IIA. Capital C. AVR is reasonable for patients with moderate AS. Stage B aortic velocity 3.0 to 3.9 meters s, who are undergoing other cardiac surgery. IIA. Capital C. AVR may be considered for asymptomatic patients with severe AS. Stage C1 and rapid disease progression and low surgical risk. IIB. Capital C. From Nishimura R.A., Otto C.M., Bono R.O., et al. 2014 AHA ACC Guideline for the Management of Patients with Valvular Heart Disease. A report of the American College of Cardiology American Heart Association Task Force on Practice Guidelines. J.M. Call Cardial 2014. 16. Chapter 16. Aortic valve disease. 24 questions. Case 1. An 81-year-old man presents for evaluation of AS. He has a history of hypertension, pacemaker implantation, and atrial fibrillation. He presents with dyspnea that worsened progressively during the last 3 months and a few episodes of angina during exercise. Figure 16.5 shows the evaluation of the aortic valve hemodynamics. This patient has a normal 55 outflow. Stroke volume index, 50.7 ml/m2, figure 16-5a. In the apical 5-chamber view, figure 16-5b, the peak aortic jet velocity is 3.7 meters s, the mean transvalvular gradient is 36 millimeters Hg, and the aortic valve area AVA is 1.01 square centimeters. Figure 16-5c also shows the measurements of transvalvular gradient from the right parasternal window. By two-dimensional echocardiography, the 55 systolic function is preserved. Videos 16.1 and 16.2, with an 55 ejection fraction estimated by the biplane Simpson method of 60%. The 55 end diastolic diameter is 51 mm, 55 outflow tract diameter 26 mm, and ascending aorta diameter 39 mm. Figure 16.5. Browser issues. Video 16.1. Browser issues. Video 16.2. 12. The patient above underwent coronary angiography to assess presence and severity of coronary artery disease prior to AVR. At that time, should the interventional cardiologist systematically cross the aortic valve and reassess the valvular hemodynamics? A. Yes. B. No. Multiplication sign. Hyphen. That's correct. Answer. B. Doppler echocardiography may underestimate the transvalvular velocity and gradient, and so the severity of the stenosis due to misalignment of the Doppler beam with transvalvular flow direction. However, Doppler rarely overestimates velocities and gradients. In this patient, the Doppler images are of good quality and those obtained from the right parasternal view clearly show a high gradient with severe stenosis. There is also no discordance between Doppler and two-dimensional echocardiography evaluation of stenosis severity and patient's symptomatic status. Therefore, there is no indication to perform an invasive assessment of aortic valve hemodynamics in this patient. Furthermore, crossing a stenotic aortic valve with a catheter is not without risk for the patient. Retrograde catheterization of the aortic valve has been shown to be associated with increased risk of cerebral emboli in patients with severe AS. Chapter 16. Aortic valve disease. 24 questions. Case 1. An 81-year-old man presents for evaluation of AS. He has a history of hypertension, pacemaker implantation, and atrial fibrillation. He presents with dyspnea that worsened progressively during the last 3 months and a few episodes of angina during exercise. Figure 16.5 shows the evaluation of the aortic valve hemodynamics. This patient has a normal 55 outflow. Stroke volume index 50.7 mlm2. Figure 16-5a. In the apical 5-chamber view, figure 16-5b, the peak aortic jet velocity is 3.7 meters s. The mean transvalvular gradient is 36 millimeters Hg, and the aortic valve area AVA is 1.01 square centimeters. Figure 16-5c also shows the measurements of transvalvular gradient from the right parasternal window. By two-dimensional echocardiography, the 55 systolic function is preserved. Videos 16.1 and 16.2, with an 55 ejection fraction estimated by the biplane Simpson method of 60%. The 55 end diastolic diameter is 51 mm, 55 outflow tract diameter 26 mm, and ascending aorta diameter 39 mm. Figure 16.5. Browser issues. Video 16.1. Browser issues. Video 16.2. 13. Coronary angiography revealed a significant stenosis of the mid-left circumflex artery. Although this was not necessary in this patient, the interventionalist measured the transvalvular gradient by the pullback method and obtained a gradient of 37 mm Hg. Which of the following statements most likely explains the discrepancy between catheterization versus echocardiography-derived transvalvular gradient? A. The phenomenon of pressure recovery downstream of the aortic valve is responsible for the lower gradient measured at catheterization versus at echocardiography. B. Hypertension during catheterization has resulted in an increase in 55 afterload and a reduction in transvalvular flow and gradient. C. The pullback catheterization method underestimates the value of transvalvular gradients obtained by echocardiography. D. Doppler echocardiography from the right parasternal window overestimates the transvalvular gradient and only the gradient from the apical window should be used. Multiplication sign. Hyphen. That's correct. Answer. B. The most likely explanation for the discrepancies between Doppler echocardiography and catheterization for the measurement of transvalvular gradient is hypertension during catheterization. The pull-back method generally overestimates the peak and mean gradients and thus the stenosis severity in patients with severe AS because of the space occupied by the catheter within the aortic valve. Chapter 16. Aortic valve disease. 24 questions. Case 2. A 72-year-old man with a history of hypertension, previous myocardial infarction, coronary artery bypass graft surgery 12 years ago, and congestive heart failure is admitted to the hospital for worsening heart failure symptoms. Two-dimensional echocardiography shows a reduced LVEF and dilated 55. Videos 16.3 and 16.4. The assessment of aortic valve hemodynamics reveals a peak aortic jet velocity of 3.6 meters s, a mean transvalvular gradient of 29 mm Hg, and an aortic valve area of 0.53 square centimeters. Browser issues. Video 16.3. Browser issues. Video 16.4. 14. What is the diagnostic test that you would do next in this patient? A. Exercise stress echocardiography. B. Full dose, up to 40 kg min, dobutamine stress echocardiography. C. Full dose, up to 40 kg min, dobutamine stress echocardiography with contrast. D. Low dose, up to 20 kg min, dobutamine stress echocardiography. E. Low dose, up to 20 kg min, dobutamine stress echocardiography with contrast. F. Right left-sided heart catheterization and coronary angiography. Multiplication sign. Hyphen. That's correct. Answer. E. In patients with low 55 ejection fraction, low flow, low gradient as, a low dose, up to 20 kg min, dobutamine stress echocardiography is useful, class IIA, to assess its severity and evaluate 55 contractile reserve. Exercise stress testing is contraindicated in symptomatic patients with severe AS, class 3. Although rest echocardiography is inconclusive with regard to stenosis severity, i.e., AVA is small suggesting severe stenosis but mean gradient is low suggesting moderate stenosis. Right-left sided heart catheterization will not provide additional information beyond a resting echocardiogram because the patient will still be in low flow state during catheterization. Hence, the AVA gradient discordance and uncertainty about stenosis severity will persist with rest catheterization, and in fact a dobutamine stress catheterization would be required. The use of contrast agents during dobutamine stress echocardiography is safe and may be helpful for myocardial visualization and assessment of 55 ejection fraction. Contrast should be used in this patient given that 2 consecutive segments or less than 80% of myocardium was not visible. Hence, the optimal next step in this patient is to perform a low-dose dobutamine stress echocardiogram with injection of contrast. Chapter 16. Aortic valve disease. 24 questions. Case 2. A 72-year-old man with a history of hypertension, previous myocardial infarction, coronary artery bypass graft surgery 12 years ago, and congestive heart failure is admitted to the hospital for worsening heart failure symptoms. Two-dimensional echocardiography shows a reduced LVEF and dilated 55. Videos 16.3 and 16.4. The assessment of aortic valve hemodynamics reveals a peak aortic jet velocity of 3.6 meters s, a mean transvalvular gradient of 29 mm Hg, and an aortic valve area of 0.53 square centimeters. Browser issues. Video 16.3. Browser issues. Video 16.4. 15. The patient underwent a low-dose dobutamine echocardiography with contrast. The dobutamine infusion was stopped at 10 kg min. 55 ejection fraction increased from 20% to 35% with dobutamine. Stroke volume from 45 to 59 milliliters. Mean gradient from 29 to 44 millimeters Hg. And aortic valve area from 0.53 to 0.60 square centimeters. Figure 16-6a. B. Full stop. How would you grade as severity? A. Moderate is because the resting mean gradient is less than 40 mmHg. B. Severe is because the resting aortic valve area is less than 1 cm2. C. Severe is because at the end of dobutamine infusion, mean gradient is more than 40 mmHg. D. Severe is because at the end of dobutamine infusion, mean gradient is more than 40 mmHg and aortic valve area is less than 1 cm2. Figure 16-6 pulsed wave Doppler in the 55 outflow tract. Panels A and continuous wave Doppler across the aortic valve. Panels B at rest, left panels, and peak, right panels. Dobutamine stress echocardiography. AVA, aortic valve area. LVOT, left ventricular outflow tract. MGRAD, mean gradient. PGRAD, peak gradient. SV, stroke volume. V peak, peak aortic jet velocity. VTI, velocity time integral. Multiplication sign. Hyphen. That's correct. Answer. D. In low flow state conditions, the valve may not be opened fully and so the AVA may be pseudo-severe, i.e., overestimate stenosis severity, whereas the gradient, which is highly flow-dependent, may be pseudo-normalized, i.e., underestimate stenosis severity. Hence, when there is a discordance between AVA 1.0 cm2 and mean gradient, 40 mmHg at rest Doppler examination, such as is the case in this patient, it is impossible to confirm the stenosis severity and a low-dose dobutamine stress echocardiogram should be performed to differentiate true versus pseudo-severe stenosis. Rest echocardiographic data cannot be used to confirm stenosis severity in such conditions and so answers A and B are wrong. Given that both gradient and AVA are flow-dependent but to various extents, gradient more flow-dependent than AVA and that the flow augmentation achieved by dobutamine stress may vary extensively from one patient to the other, it may be misleading to rely on only one parameter gradient or AVA to determine the stenosis severity during dobutamine stress echocardiography. The guidelines suggest a class IIA recommendation for AVR if dobutamine stress echocardiography shows a true severe stenosis defined as a mean gradient 40 mm Hg and an AVA 1.0 cm2 at any dobutamine stage, not necessarily the maximum dose stage. In this patient, the gradient increased up to 44 mm Hg and the AVA remained below 1.0 square centimeters, i.e., 0.60 cm2 during dobutamine stress. Figure 16-6. Hence, answer C is wrong and the right answer is D if the AVA gradient discordance persists with dobutamine stress e.g. stress AVA is 0.8 square centimeters and stress mean gradient is 35 mm Hg. One can calculate the projected aortic valve area at a normal flow rate. 10. 11. 12. Chapter 16. A 72-year-old man with a history of hypertension, previous myocardial infarction, coronary artery bypass graft surgery 12 years ago, and congestive heart failure is admitted to the hospital for worsening heart failure symptoms. Two-dimensional echocardiography shows a reduced LVEF and dilated 55. Videos 16.3 and 16.4. The assessment of aortic valve hemodynamics reveals a peak aortic jet velocity of 3.6 meters s, a mean transvalvular gradient of 29 mm Hg, and an aortic valve area of 0.53 square centimeters. Browser issues. Video 16.3. Browser issues. Video 16.4. 16. The operative risk for surgical AVR in this patient is A. High risk. 8% risk of 30-day mortality because rest 55 ejection fraction is less than 50%. B. High risk. 8% risk of 30-day mortality because of the absence of 55 flow reserve during dobutamine stress. C. Intermediate risk. 6%-8% risk of 30-day mortality because rest 55 ejection fraction is less than 50% but there is significant 55 flow reserve during dobutamine stress. D. Intermediate risk. 6%-8% risk of 30-day mortality because rest 55 ejection fraction is less than 50%, but there is significant improvement in ejection fraction during dobutamine stress. Multiplication sign. Hyphen. That's correct. Answer. C. In patients with low 55 ejection fraction, operative risk would be at least intermediate 55 contractile reserve is, however, useful to further enhance operative risk stratification. 55 contractile reserve has been defined as a percent increase in stroke volume 20% during dobutamine stress echocardiography. In the most recent guidelines, 55 contractile reserve has been renamed 55 flow reserve because the change in stroke volume during dobutamine stress echocardiography may be influenced by many other factors besides 55 contractile reserve per se, i.e., severity of AS, afterload mismatch, concomitant change in mitral regurgitation. This patient had a 31% increase in stroke volume with dobutamine stress and so would be considered at intermediate surgical risk. Previous studies reported 30-day mortality of 8%-30% following surgical AVR versus 5%-8% in those with flow reserve. A deterioration or absence of increase in 55 ejection fraction during dobutamine stress echocardiography is often associated with worse prognosis. However, an improvement in ejection fraction, such as observed in this patient, has limited specificity because it may be due, in large part, to worsening of concomitant mitral regurgitation during dobutamine stress. Hence, answers A, B, and D are wrong and answer C is right. This patient has intermediate operative risk because he has reduced LVEF at rest and significant 55 flow reserve during dobutamine stress echocardiography. Key points. In patients with low LVEF, low flow, low gradient AS, low dose dobutamine stress echocardiography is essential to differentiate true versus pseudo-severe stenosis and 2. To assess the presence of 55 flow reserve, which is useful for operative risk stratification. Contrast should be used in patients with poor echogenicity, i.e., 2 consecutive segment not visible. 11. Chapter 16. Aortic valve disease. 24 questions. Case 3. A 72-year-old woman with a history of hypertension and undergoes routine clinical and echocardiographic follow-up. 3 years ago, Doppler echocardiogram showed a stroke volume SV of 71 milliliters, indexed stroke volume 44 ml/m2, an AVA of 1.20 square centimeters, indexed AVA of 0.75 cm2/m2. A mean gradient of 21 mm Hg, 55 ejection fraction of 70%, and an 55 end diastolic diameter of 47 mm. The echocardiogram performed today shows an SV of 48 milliliters, indexed SV, 30 ml/m2, an AVA of 0.89 square centimeters, indexed AVA 0.50 cm2/m2, a mean gradient of 24 mm Hg, and 55 ejection fraction of 60%, and an 55 end diastolic diameter of 42 mm. Video 16.5. The patient did not report any symptoms. Browser issues. Video 16.5. 17. Your recommendation for this patient is: A. Schedule a follow-up echocardiogram in 2-3 years. B. Perform an exercise test. C. Perform an exercise stress echocardiography. D. Perform full-dose dobutamine echocardiography. E. Perform low-dose dobutamine stress echocardiography. Multiplication sign. Hyphen. That's correct. Answer. C. 3 years ago, this patient had a normal 55 ejection fraction, a normal 55 outflow, and moderate as. Compared to this previous study, the patient had a significant decrease in 55 ejection fraction, a reduction in 55 end diastolic diameter, and a marked decrease in SV index. The SV index measured on this study is 30 mlm2, which is lower than the cut point value of 35 mlm2 proposed in the guidelines to define low flow in patients with AS. The patient would thus be in a low flow state, although the 55 ejection fraction 60% is within normal range. The AVA has decreased markedly and is now in the severe range, whereas the gradient remains in the moderate range despite a mild increase compared with the previous study. The highest mean transvalvular gradient found after careful multi-window interrogation by continuous wave Doppler was 24 mm Hg. The measurement of SV in the 55 outflow tract is subject to technical errors. In particular, the measurement of the 55 outflow tract diameter may be challenging in patients with calcific AS. An underestimation of this diameter may result in an underestimation of SV and AVA, and thus in a misclassification of the flow status, low versus normal, and stenosis severity severe versus moderate. It is thus important to corroborate the measurement of 55 outflow tract SV by other methods. The biplane Simpson method is of limited utility for this purpose because it underestimates the 55 volumes and thus the SV. Due to frequent foreshortening the 55 apex in the apical 4 and 2 chamber views, the assessment of 55 volumes by three-dimensional echocardiography provides an accurate measure of 55 SV, but this imaging modality requires good quality images. In this patient, three-dimensional echocardiography was not available. However, an estimation of 55 SV was obtained by multiplying the 55 end diastolic volume estimated by the T-Charles formula by the 55 ejection fraction LVEF. To avoid underestimation of the 55 end diastolic volume by T-Charles, it is important to measure the 55 end diastolic diameter below the septal bulge frequent in patients with AS, that is, where the 55 cavity is the largest. In this patient, the 55 SV estimated by this method was very similar to the SV measured in the 55 outflow tract. Of note, this method cannot be used if moderate or greater mitral regurgitation is present, which was not the case in this patient. These data confirm that this patient has a low flow state despite normal 55 ejection fraction, an entity named paradoxical low flow. This low flow state is associated with a small AVA but a low gradient N. Therefore, the stenosis severity remains undetermined with rest echocardiography. The patient reports no symptoms. However, about 30% of patients with severe AS claiming to be asymptomatic in fact have exercise-limiting symptoms at the time of exercise testing, and these patients have worse outcomes. Hence, to guide the management of this patient, it is important to confirm both the symptomatic status and the stenosis severity. Exercise stress echocardiography fulfills these two objectives, and the right answer is thus C. Exercise testing will determine the symptom status but not the stenosis severity, and dobutamine stress echocardiography will determine the stenosis severity but not the symptomatic status. 12. 13. 14. Chapter 16. Aortic valve disease. 24 questions. Case 3. A 72-year-old woman with a history of hypertension and undergoes routine clinical and echocardiographic follow-up. 3 years ago, Doppler echocardiogram showed a stroke volume SV of 71 milliliters, indexed stroke volume 44 ml/m2, an AVA of 1.20 square centimeters, indexed AVA of 0.75 cm2/m2, a mean gradient of 21 mm Hg, 55 ejection fraction of 70%, and an 55 end diastolic diameter of 47 mm. The echocardiogram performed today shows a SV of 48 milliliters, indexed SV 30 ml/m2, an AVA of 0.89 square centimeters, indexed AVA 0.50 cm2/m2, a mean gradient of 24 mm Hg, and 55 ejection fraction of 60%, and an 55 end diastolic diameter of 42 mm. Video 16.5. The patient did not report any symptoms. Browser issues. Video 16.5. 18. The patient underwent exercise stress echocardiography with a modified Bruce protocol. She stopped walking after only 4 minutes 39 seconds due to chest pain. She had moderate dyspnea at the time of test termination. Electrocardiogram and echocardiogram did not show any sign of ischemia. The expected maximum heart rate was 72%. Stroke volume increased to 59 milliliters, mean gradient to 29 mm Hg, and an AVA to 0.92 square centimeters. Projected aortic valve area at a normal flow rate, 250 mls, was calculated at 0.94 square centimeters with the use of the following formula. Figure 16.7. Where AV rest and crest are aortic valve area and flow rate, stroke volume divided by ejection time, at rest, respectively, and AV at peak and peak are AVA and Q during peak exercise, respectively. Your recommendation is: A. Schedule follow-up echocardiogram in 2-3 years because AS is moderate. B. Schedule follow-up echocardiogram in 1 year or less because AS is severe but patient is asymptomatic. C. Confirm that AS is severe by multi-detector computed tomography, MDCT, and refer the patient to surgical AVR because AS is severe and the patient is symptomatic on exercise. D. Confirm that AS is severe by MDCT and refer the patient to transcatheter AVR because AS is severe, and the patient is symptomatic on exercise and is at high surgical risk. Figure 16.7.55 Outflow tract diameter measurement. Upper left panel. Pulsed wave Doppler in the 55 outflow tract and continuous wave Doppler across aortic valve at rest. Upper panels. And peak. Bottom panels exercise stress echocardiography. Calculation of the projected aortic valve area at normal flow rate. Bottom right panel. AVA. Aortic valve area. LVOT. Left ventricular outflow tract. M-grad. Mean gradient. P-grad. Peak gradient. Q. Transvalvular flow rate. SV. Stroke volume. V peak. Peak aortic jet velocity. VTI. Velocity time integral. Multiplication sign. Hyphen. That's correct. Answer. C. The patient had symptoms at a low level of exercise and the test was stopped prematurely. Hence, the patient is symptomatic. There was a minimal increase, +9%, in stroke volume with exercise stress echocardiogram and the discordance in AV gradient that existed at rest. 0.89 cm2, 24 mm Hg persisted at exercise 0.92 cm2, 29 mm Hg. However, because of shortening in 55 ejection time, the mean transvalvular flow rate increased by 20%, which allowed the calculation of the projected AVA at a normal flow rate. This parameter provides an estimation of what the AVA would be at a standardized flow rate of 250 mls. In this patient, the projected AVA is 0.94 square centimeters, figure 16.7, which would suggest a true severe stenosis. Hence, answers A and B are wrong. This patient with paradoxical low flow, low gradient as and preserved LVEF is symptomatic and has a severe stenosis according to the findings of exercise stress echocardiography. According to the ACC AHA guidelines, AVR is reasonable class IIA in symptomatic patients who have low flow low gradient severe AS, stage D3 who are normotensive and have an LVEF 50% if clinical, hemodynamic, and anatomic data support valve obstruction as the most likely cause of symptoms. This patient should thus be referred to AVR and answer C is right. This patient is, however, not at high surgical risk and thus answer D is wrong. Of note, in patients with discordant echocardiographic findings, it may be helpful to corroborate the stenosis severity using another imaging modality. Aortic valve scoring using multi-detector computed tomography is the best modality for this purpose. The aortic valve calcification score measured in this patient was 3720 AU figure 1613, thus corroborating the presence of severe stenosis. For a woman, the cut point value of aortic valve calcium score to identify severe stenosis is more than 1200 AU. Figure 1613. Key points. Exercise stress testing is recommended to confirm symptomatic status in patients with severe or possible severe, as who claim to be asymptomatic. Stress echocardiography and calculation of the projected AVA at normal flow rate may be useful to corroborate the stenosis severity in patients with paradoxical low flow, low gradient as and preserved LVEF. Assessment of aortic valve calcification load is a flow-independent marker of a severity that may be useful in patients with paradoxical low flow, low gradient as in whom stress echocardiography is not feasible or not conclusive. 13. 14. 15. Chapter 16. Aortic valve disease. 24 questions. Case 4. A 62-year-old man underwent a clinical examination because of reduced exercise capacity and dyspnea. At cardiac auscultation, a loud 3/6 ejection murmur radiating to the neck vessels was noted. The patient underwent Doppler echocardiography, which shows mild 55 hypertrophy, normal 55 ejection fraction 60%, normal flow, stroke volume 95 milliliters, stroke volume index 47 mlm2, and a calcified aortic valve with a peak aortic jet velocity at 3.4 meters s, an AVA of 0.90 square centimeters, and a mean gradient of 29 millimeters Hg. 19. How would you grade a severity? A. Moderate as because peak aortic jet velocity is less than 4 meters s and mean gradient is less than 40 mmHg and transvalvular flow is normal. B. Severe as because aortic valve area AVA is less than 1 cm2 and transvalvular flow is normal. C. Severe as because AVA is less than 1 cm2 and indexed AVA is less than 0.60 cm2/m2. D. It is not possible to determine stenosis severity with rest echocardiography and we need to perform stress echocardiography. E. It is not possible to determine stenosis severity with rest echocardiography and we need to assess aortic valve calcification by MDCT. Multiplication sign. Hyphen. That's correct. Answer. E. This patient has a peak aortic jet velocity, 4 meters s and a mean gradient, 40 mmHg with a normal 55 ejection fraction and a normal flow, stroke volume index, 35 mlm2. According to the guidelines, he would thus be considered as having moderate as and no indication for AVR, even if he has a small AVA and he is symptomatic. However, recent studies reported that a substantial proportion of patients with discordant grading, i.e., mean gradient, 40 mmHg and AVA 1 cm2, and normal flow may nonetheless have a hemodynamically severe AS. This subset of patients with normal flow, low gradient AS is highly heterogeneous and may include patients with moderate AS and measurement error in the stroke volume and thus in the AVA. 2. Patients with moderate AS and small body surface area. In such case, AVA is small but indexed AVA is more than 0.6 cm2/m2, thus suggesting moderate stenosis. And 3. Patients with severe AS and discordant grading due to inconsistencies in the AVA gradient cut point values used in the guidelines. Indeed, at a normal flow rate, The AVA cut point value of 1.0 square centimeters generally used to define severe stenosis does not correspond to a gradient of 40 mm Hg but rather to a value of 30-35 mm Hg. In the patients with normal flow, low gradient but small AVA, it is difficult from the resting echocardiogram to be certain that stenosis is moderate or severe. Hence, answers A, B, and C are wrong. The first step in these patients is to rule out errors in the measurement of stroke volume and AVA and ensure that the maximum velocity gradient has been recorded by multi-window interrogation. Once measurement errors have been ruled out, the next step, if the patient is symptomatic such as is the case in this patient, is to confirm stenosis severity. Given that some of these patients category 3, described earlier, may have a severe stenosis despite the presence of low gradient and normal flow, stress exercise or dobutamine, echocardiography may not be the best approach in these patients because the transvalvular flow rate is already normal. Answer D is wrong. The assessment of aortic valve calcification load by MDCT may be helpful to corroborate the stenosis severity in the context of patients with normal flow, low gradient as. The correct answer is thus E. 14, 15, 16, 17. Chapter 16. Aortic valve disease. 24 questions. Case 4. A 62-year-old man underwent a clinical examination because of reduced exercise capacity and dyspnea. At cardiac auscultation, a loud 3/6 ejection murmur radiating to the neck vessels was noted. The patient underwent Doppler echocardiography, which shows mild 55 hypertrophy, normal 55 ejection fraction 60%, normal flow, stroke volume 95 milliliters, stroke volume index 47 mlm2, and a calcified aortic valve with a peak aortic jet velocity at 3.4 meters s, an AVA of 0.90 square centimeters, and a mean gradient of 29 millimeters Hg. 20. The patient underwent an MDCT without contrast to assess aortic valve calcification. Figure 16.8. The aortic valve calcification score is 1810 AU. Your recommendation is: A. Patient has severe AS and should be referred for AVR. B. Patient has severe AS but gradient is less than 40 mmHg. A medical and echocardiographic follow-up should be planned in 6 months. C. Patient has moderate AS and should have clinical and echocardiographic follow-up in 1 year. D. Patient has moderate AS and other potential causes of symptoms should be investigated and treated. E, C and D. Figure 16.8 multi-detector computed tomography showing aortic valve calcification. Red circle. Multiplication sign. Hyphen. That's correct. Answer. Recent studies emphasize that different cut point values of aortic valve calcification load should be used in women versus men to identify severe stenosis. Women reach hemodynamically severe stenosis with a lower amount of aortic valve calcium, even after adjustment for smaller body size or annulus size. Table 16.1. In this male patient, aortic valve calcification load is 1810 AU and aortic valve calcification density is 426 OCM2. The cut point values that have been suggested to identify severe stenosis in men are more than 2000 AU for aortic valve calcium load and 500 OCM2 for aortic valve calcium density. Therefore, this patient likely has moderate AS and there is no indication for AVR. Hence answers A and B are wrong. This patient is symptomatic and should have a close clinical echocardiographic follow-up. The symptoms in this patient may be related to other diseases including hypertension and coronary artery disease or the coexistence of severe disease e.g., moderate AS and moderate hypertension. Hypertension is often underdiagnosed and undertreated in patients with AS, and it may contribute to the occurrence of symptoms and adverse events. Therefore, answer E, C and D is correct. Table 16.1. Recommendations for the grading of AS severity. Mild. moderate, severe. Echocardiography. Peak aortic jet velocity, ms. 2.6 to 2.9. 3.0 to 3.9. 4. Mean gradient, mmHg. 20. 20-39. 40. Aortic valve area, cm2. 1.5. 1.1 to 1.5. 1.0. Indexed AVA cm2/m2. 0.90. 0.61 to 0.90. 0.6. Velocity ratio, 0.50. 0.26 to 0.50. 0.25. Computed tomography. Aortic valve calcium load AU. Men. M-. M-. 2000. Women. M-. M-. 1200. Aortic valve calcium density, OCM2. Men. M-. M-. 500. Women. M-. M-. 300. AVA, aortic valve area. A velocity ratio or Doppler velocity index, ratio of the 55 outflow tract TVI to the aortic jet TVI, where TVI is the time velocity integral. B. The density is the calcium load divided by the cross-sectional area of the aortic annulus. Key points. In symptomatic patients with preserved LVEF, normal flow and discordant echocardiographic findings e.g., small AVA and low gradient, aortic valve calcium scoring with MDCT may be useful to corroborate the stenosis severity. Lower cutoff values of aortic valve calcification score should be used in women versus men to identify hemodynamically severe as 15. 6. Chapter 16. Aortic valve disease. 24 questions. Case 5. A 34-year-old asymptomatic man is referred for evaluation of AR. His Doppler echocardiogram shows a bicuspid aortic valve with AR videos 16.6 to 16.9, a dilated 55, and diastolic diameter 76 mm, and systolic diameter 49 mm, an aortic root diameter of 48 mm, and an 55 ejection fraction estimated at 45%. The effective regurgitant orifice area, AROA, measured by the PISA was 0.36 square centimeters, and there was flow reversal in the descending aorta. Figure 16-9 AC. Browser issues. Video 16.6. Browser issues. Video 16.7. Browser issues. Video 16.8. Browser issues. Video 16.9. Figure 16.9 Panels A and B. Assessment of effective regurgitant orifice area, AROA, by the PISA method. Panel C. Pulsed wave Doppler image of blood flow in the descending aorta. 21. Which of the following statements regarding severity of AR is correct? A. Aortic regurgitation is severe because the aortic regurgitant jet extends below the midventricular level and the area of the jet is large. B. Aortic regurgitation is severe because AROA is more than 0.3 cm2 and there is a holodiastolic flow reversal in the descending aorta. C. Aortic regurgitation is not severe because 55 end systolic diameter is less than 50 mm. D. Aortic regurgitation is severe because there is a holodiastolic flow reversal in the descending aorta and the 55 ejection fraction is less than 50%. Multiplication sign. Hyphen. That's correct. Answer. B. According to the 2014 ACC AHA guidelines, the parameters and criteria that are proposed to define severe AR are a ratio of regurgitant jet width to LVOT diameter 65%, a width of the vena contracta, 0.6 cm, the presence of holodiastolic flow reversal in the descending aorta, an arrow a 0.3 square centimeters, a regurgitant volume 60 ml beat, and a regurgitant fraction 50%. Table 16.3. In addition, the diagnosis of chronic severe AR requires evidence of significant 55 dilation. Chapter 16. Aortic valve disease. 24 questions. Case 5. A 34-year-old asymptomatic man is referred for evaluation of AR. His Doppler echocardiogram shows a bicuspid aortic valve with AR videos 16.6 to 16.9, a dilated 55, and diastolic diameter 76 mm, and systolic diameter 49 mm, an aortic root diameter of 48 mm, and an 55 ejection fraction estimated at 45%. The effective regurgitant orifice area, AROA, measured by the PISA was 0.36 square centimeters, and there was flow reversal in the descending aorta. Figure 16-9 AC. Browser issues. Video 16.6. Browser issues. Video 16.7. Browser issues. Video 16.8. Browser issues. Video 16.9. Figure 16.9 Panels A and B. Assessment of effective regurgitant orifice area, AROA, by the PISA method. Panel C. Pulsed wave Doppler image of blood flow in the descending aorta. 22. Your recommendation for this patient is: A. Exercise test to confirm symptom status. B. AVR. C. Aortic valve repair or replacement and aorta replacement. D. Close follow-up and intervention at the time of symptoms onset. Multiplication sign. Hyphen. That's correct. Low. Cap. Kappa. Key points. A quantitative and integrated approach should be used to assess the severity of AR. The aortic size cut point for considering concomitant aortic root replacement is lower, 4.5 centimeters, in patients with a bicuspid valve compared with those with a tricuspid valve. Chapter 16. Aortic valve disease. 24 questions. Case 6. An asymptomatic 31-year-old woman was referred for an echocardiography because of the presence of a 4/6 systolic murmur, Doppler echocardiography reveals the following. Bicuspid aortic valve. Aortic regurgitation AR with a vena contracta width of 0.7 cm. Figure 1610. Aroa of 0.31 square centimeters. AVA of 1.3 square centimeters. Mean transvalvular gradient of 45 mm Hg. 55 end. Diastolic diameter of 56 mm. 55 end systolic diameter 33 mm. 55 stroke volume of 113 milliliters. And 55 ejection fraction of 65%. Video 1610 to 1613. Figure 1610. Browser issues. Video 1610. Browser issues. Video 1611. Browser issues. Video 1612. Browser issues. Video 1613. 23. What is your diagnosis in this patient? A. Severe AR. B. Severe AS. C. Severe AR and severe AS. D. Moderate AR and severe AS. E. Severe AR and moderate AS. F. Moderate AR and moderate AS. Multiplication sign. Hyphen. That's correct. Answer. E. This patient has a bicuspid valve with mixed dysfunction, that is, as and AR the vena contracta width, 0.6 cm, Aroa, 0.3 cm2, and 55 stroke volume, 100 ml, all suggest the presence of severe AR. Table 16.3. The severity of AS is, however, more difficult to assess because of the presence of significant AR, which increases the flow across the aortic valve. In such conditions, the transvalvular gradient, which is highly flow dependent, may overestimate the stenosis severity. This is, in fact, the opposite situation as the one observed in patients with low flow, low gradient AS. The calculation of AVA by the continuity equation method remains valid in presence of significant AR because both the numerator and the denominator of the equation are increased to the same extent. The transvalvular gradient, 45 mmHg, suggests the presence of severe AS, but the patient is in a high flow condition, stroke volume index of 76 ml/m2, and in such a case, the gradient overestimates stenosis severity. The AVA is 1.3 square centimeters and thus indicates that the stenosis is in fact moderate. One can also calculate the gradient corrected for 55 outflow tract, LVOT, velocity as follows. Corrected gradient equals 4, peak 2, VLVOT2. The corrected gradient in this patient is 37 mm Hg, which is also consistent with moderate AS. So the correct answer is E, severe AR and moderate AS. Although the uncorrected velocity and gradient overestimate the severity of AS in presence of significant AR, they are Chapter 16. Aortic valve disease. 24 questions. Case 6. An asymptomatic 31-year-old woman was referred for an echocardiography because of the presence of a 4/6 systolic murmur. Doppler echocardiography reveals the following. Bicuspid aortic valve. Aortic regurgitation AR with a vena contracta width of 0.7 cm. Figure 1610. Aroa of 0.31 square centimeters. AVA of 1.3 square centimeters. Mean transvalvular gradient of 45 mm Hg. 55 end. Diastolic diameter of 56 mm. 55 end systolic diameter 33 mm. 55 stroke volume of 113 milliliters. And 55 ejection fraction of 65%. Video 1610 to 1613. Figure 1610. Browser issues. Video 1610. Browser issues. Video 1611. Browser issues. Video 1612. Browser issues. Video 1613. 24. Your recommendation for this patient, K6, is A. Follow-up echocardiogram in 1 year. B. Follow-up echocardiogram in 3-6 months. C. AVR with a mechanical prosthesis. D. AVR with a bioprosthesis. EAVR with a pulmonary autograft Ross procedure or homograft. F. Transcatheter aortic valve implantation. Multiplication sign. That's correct. Answer. B. This patient with severe AR and moderate AS is asymptomatic and does not have any criteria for intervention related to the severe aortic valve disease. Tables 16.2 and 16.4. There is no clear indication for intervention in this patient if one refers to the guidelines recommendations for AR or for AS. It should be emphasized that there is no specific recommendation for patients with mixed valve disease, except that they may require serial evaluations at intervals earlier than recommended for single valve lesions. Thus, this patient requires close clinical and echocardiographic follow-up, and answer A is wrong and answer B is correct. Of note, if this patient had moderate AR instead of severe, and moderate AS with a peak jet velocity 4 meters s and a mean gradient 40 millimeters Hg, she would still be considered as having severe aortic valve disease and would thus have an indication of AVR in presence of symptoms. Table 16.2. Recommendation for intervention in AS. Recommendations.